most common text I get is, Amme Folani Folani is got MS or Parkinson's to Iran. What should they take?
Try to live a healthy lifestyle. Don't ask for medications. Go have a cigarette outside and go drink like this much alcohol tonight and expect to get better. It's not going to happen.
یعنی خجالت نمیکشن. They're not. There's not like they don't even need a pretense. Like it's like I'm going to the beach. Hit me up with some Ozempic. Well, hi there. Welcome to episode 345 of Roqe. I'm Jian Gomeshi. And before we get started today's show, a little word for anyone that needs to know. Don't be surprised that many Iranians support Trump. Okay, now hear me out. It's an emotional time for some, no doubt. Just don't be surprised that many Iranians support Trump. This comes to mind after a good friend, a Canadian who is non-Iranian, contacted me when the American election results were coming in on Tuesday to express surprise that she was seeing some of her Iranian acquaintances celebrating a prospective Trump victory. How could Iranians support the guy who is so famously called anti-immigrant, she asked. Didn't he want a Muslim ban? Doesn't your Iranian community understand that he's aligned with white supremacists? Well, no, yes, that might be a tad reductive. You see, if one of the great narratives that is emerging, for better or worse, from the autopsy of this freshly finished election is the surprise that, say, so many Latinos went for the GOP, don't be so shocked that many Iranians turned the same key. And much like the expectation that Latinos were meant to be Democratic voters, there's a similar misconception based on patterns of the past that Iranians, as immigrants, will shy away from Republicans and any kind of American conservative, more nationalist policy. It is a misconception, and there are reasons to explore why there are Iranians who are pro-Trump and more. Flashback to our Roqe live show last month in Toronto, where a sold-out crowd of over 400 Iranians from different age groups, different walks of life, different perspectives, sitting in a theater in the progressive country of Canada in the most multicultural city in the world, were almost unanimous in wildly cheering for Donald Trump when I questioned who they would prefer to win the American presidential race. Oh yes, something is going on. Don't be surprised that many Iranians support Trump. And please don't get all worked up if you're not a fan of the president-elect and you think I now stand for all the things you reject. Look, I have been anything but shy about speaking of Trump's shortcomings. If you listen to this program, you have heard me repeatedly talk about his propensity for prevarication, fabrication, misrepresentation, scapegoating, chaos. And having interviewed the guy, I don't exactly consider him Mandela. But maybe it's instructive to understand the inclinations of the Iranian diaspora and to undo some of the expectations and boxes Iranians get put in, and that maybe, just maybe, some of the support for Trump has to do with the failures of the current administration when it comes to Iran. Look, first things first, Iranians are not a monolith, and don't think and vote as one. This is something that our community knows very well, disunity being our most celebrated vice. But the world may need to catch up to the notion that we're not just one type of rice. Yes, even in the diaspora, there are wild variations in Iranian thinking. Second, there are many Iranians that agree with the GOP and Donald Trump on policy. It's not just the folks in Orange County that, for better or for worse, like the economic messaging or some of his social conservatism or even some of the anti-immigration stuff. That's right. Many, many Iranians are part of the non-white people who didn't reflexively hate Trump. Don't be surprised that many Iranians support Trump. But beyond all of that, and no matter where you may be on the thinking of whether we've just entered a new level of dystopia with a fascist at the helm, or we are happily moving into a post-wokeism realm, when it comes to Iranians, we simply cannot dismiss the policies and actions taken in the last 4 years in response to the universally despised regime in Iran. Despised by the Iranian people, that is. You see, could it be that some of the support for Trump is not about the man, his party, his bluster, but about the actions of the Biden administration for the last 4 years? When the current U.S. government has repeatedly signaled a desire to break bread with the totalitarian regime in Iran, can you blame Iranian expats for turning away? When the Biden admin was continuing to enable the regime at the height of the global protests after the killing of Mahsa Amini, is it a surprise that Iranians were not okay? When the response to the shooting of kids in the streets of Iran was to say a few empty words about democracy and throw a Nowruz garden party, we were all filled with dismay. Look, I have no idea if Trump will be the right person in power to help get rid of this murderous regime in Iran, and I know many of you definitely do not think he is. But after the engagement of the Biden years and the stated desire to deal with the regime once more, it's not a shock that many Iranians are fed up and wanted to reject the Democrats to the core. Don't be surprised that many Iranians support Trump. There are uncharted days ahead and potentially scary ones with worrisome policies or actions. But if the idea is that Trump became an avatar for those who felt alienated in the U.S., who felt unheard and were searching for something new, turns out it wasn't just white middle America, but a lot of Iranians too. Oh, we've got a brand new episode of Roqe coming your way with the great Ozempic debate today. Dr. K, Dr. Afruz Demeri, Dr. Jaleh Hassanlou will all be joining us. Plus, Pega is here with the roundup. Let's get started. What a time it is to be alive. This is Roqe, episode 345. It's November 7th, 2024. This is Roqe. Hi there, welcome to episode 345 of Roqe. I am Jian Ghomeshi. Hello to you from Toronto, hello to you from Canada. Salam Dustan Aziz, Durud Bar Shoma. Hope you're doing well. Wherever you're tuning in from around the world, hello, smart Pega, resplendent in red. Is this Trump red or Liberal Party of Canada
actually,
red?
I just coincidentally wore red, but hello.
You're part of the red wave? Are you?
Honestly, I wasn't thinking about it when I put this on today, that this is the
this is what
conversation
happens.
we were going to be having.
We're 2 days in and now you're wearing red.
That's it.
Yeah.
What a time.
What a time.
Oh, I can't believe it. I was up as late as I possibly could watching the election results, and then woke up in the morning to news of our new president.
Right. Oh, you didn't stay up for that?
I didn't. No,
I
fell
stayed
asleep.
up. I stayed up. And then received
numerous
text messages and messages from all of my friends and family members who were distraught and freaked out and scared, and then some who were excited. But it was definitely a polarized reaction.
I wasn't surprised though.
You weren't surprised by the Trump victory?
No.
In the last few days, I predicted a Trump victory for months, but in the last few days, I thought that there was a Harris surge. I got caught up in the Taylor Swift, Cardi B. No, I'm kidding. That's not why. But I did feel like, Trump seemed he was having a bad week, the final week, and he seemed like he was in a bad mood. I thought they were getting intel saying that, it doesn't look like it's looking good. So it was impossible to call. But there you go.
Yeah, I don't know.
I was trying with that essay to. I never tell people who I vote for.
Right.
I was trying my best to walk the line. It's impossible with this, right? Because it really is impossible, because anything you say,
someone's going to find offense.
Well, if you say anything other than Trump is evil, if you try and bring any analysis to this, there's a certain cohort which are offended. And then if you say, Trump is the greatest.
Sorry.
Yeah. Is this a reaction as well?
You said Trump is the greatest, and I just had to.
Yeah, I mean, but I also, I really, that was heartfelt. I mean, we sat here. If anybody's going to say to me, what are you bringing this up for, the Biden administration policy on Iran, is because, we sat here week after week, essay after essay, roundup after roundup, talking about how the Biden administration wasn't acting on Iran, and people don't forget that stuff. Yeah. People don't forget that stuff. And I dare say it's similar here in Canada, where there may be a lot of reasons for the disenfranchisement, the disinterest in Justin Trudeau from the population here, including Iranians. Also with Trudeau, you have this. Let me try Liz Truss, Boris Johnson. See other world leaders from the past.
No, it looks like it's just Trump and Trudeau.
Trump.
That's it.
Current leaders.
Yes.
Those were past British prime ministers. Keir Starmer. No? Okay.
Nope, still good.
No, it's still good. So yeah, I think in Canada, as we saw the Iranian community the realignment of the Iranian community in our own unscientific study. But I mean, it seems way too clear when it's 100-0 at our Roqe Live in terms of the poll we took, then you know that something's going on. The realignment from supporting the Liberal Party to moving conservative, it's got to have to do with policy on Iran to a certain extent. People, and people wanting our governments in the West to be harder on the regime and not to be playing footsie with them, and no New Deal, no reformist approach, all of that stuff. So I got to think that was part of the mix. I was trying to say, I know there's a lot of reasons, as we know. All Iranians know that there's Iranians that support Trump and there's Iranians that don't support Trump. And, it's a mixed bag of people, and depending on where you are in the country and all of that. But this time, I think Iran policy has made a big difference.
I think it definitely has. And you mentioned in your essay, and I absolutely agree. I think the most important thing is that across the diaspora, there's just an appetite for change, with whether it be U.S.-Iran relations or Canadian-Iranian relations. And there just has to be a change. What we've seen with the current government, whether it's, the previous government in the United States with Biden, or what we've seen with Trudeau here in Canada, there just needs to be a change. What we've seen with the way they've handled things with the Islamic Republic of Iran is not anything that any Iranian, I think, agrees with. And we saw that time and time again. And like you said, we talked about it over the course of the Women, Life, Freedom movement. We saw it with, we're still seeing it. I mean, we still continue to see it. And I think that's why it's not a surprise, and that's why it wasn't a shock to me.
I mean, it's going to be, we're going to have to react now to the policies of Trump.
Yes.
I'm really not totally sure what they're going to be. I mean, is anyone? Do we know what? I know there's a hope. I mean, Nufti put out a press release saying, maximum pressure on Iran, all of that. But I don't have as much faith that there's going to be that kind of consistency from the Trump administration. I hope there will be, in terms of, wanting to take a
harder approach.
A harder approach that is and a smart one. Not just a.
See, I'm worried about
drop bombs on Iran.
Harder approach, though. Even if it's not the drop bombs on Iran, and even if it is through sanctions and things like that, I don't know how well that's going to go with the economic crisis that we're seeing inside of Iran. I actually think that might.
So you don't support sanctions now?
No, not that I don't support it, but I think a hard approach right now with the current economic climate in Iran might not actually work so well, because I think then people inside of Iran will lose that momentum of, let's look at change and things like that, because they're suffering so much inside the country. They can't even put bread on the table.
We're going to have a long conversation about that on an episode that will be coming very soon. In fact, I think we're trying to organize for next week's show if not a debate, a conversation between two Iranian Americans who are on either side of this of the Trump Biden, what do we call it now? Other sides of the aisle. I mean, there's only one side now.
That's right.
They won everything.
That's right.
That
I was surprised about, actually.
Yeah, I never like that.
No,
I never like one. I mean, not that. When you grow up and you're a political science and history major, like I was, you learn to call them Tweedledee and Tweedledum. There's not that much difference. They're both corporate parties, all of that stuff, right? But there are some significant differences, especially when it comes to social policy, abortion, whatever. I never want all the chips in one pile. I like the checks and balances system.
I do too.
Here in Canada too. You never want. I always like minority governments. When they're so.
It leaves at least a little bit of room for discussion.
And if he wins the House now, if the MAGA people win it's a lot. It's a lot. So, speaking of debates, today can we move off Trump now?
We can.
Good thing that there won't be any more Trump conversations. We had 8 years of that. That was enough. It's over. Oh wait, another 4 years of talking about Mr. Trump.
We've got another debate that's been.
We have another debate that's
for some time.
Yeah, and we've been wanting to do this for a little while. This is the Ozempic debate. We've titled it a debate. I mean, the kind of people that we have on, our dear friend Dr. K from New York, our friend Dr. Afrouz Demary, who's in California, and Dr. Jaleh Hassanlou, which will be joining us here in the studio. She's in Toronto. They're all nuanced thinkers. So I don't anticipate anybody's going to come in going, you're crazy if you use Ozempic, or it's the best, it's the wonder drug. But interestingly, leading up to today, and I'll mention this to them, I did my own little survey of a number of probably like 10 or 12 different doctors that I know.
Okay.
and I asked them about Ozempic.
I thought you were going to say people that you know who are taking it or weren't taking it or things like that.
I can neither confirm nor deny how many people I know who are taking it. But no, 10 or 12, and no word of a lie, complete disagreement.
Really?
At least off the record. Yeah. One doctor, she's a doctor in Aurora, she actually said it is the miracle drug, wonder drug, Ozempic. This is the drug that was part of the drug that used for type 2 diabetes and now is being used as a weight loss drug. We'll get into all of that once we get into this. But so she's in the camp of this is a miracle drug. This is wondrous and wonderful. And then on the other side, I got some, I would never prescribe that answers for weight loss. I would never prescribe that.
I think it's become one of those things that a lot of people like to hate on it. And my personal stance, at least, on it is that it's become such a trend that there's so much misinformation and there's so much, for lack of a better term, unneeded, unnecessary opinion around it. Like, I really think, the people that we have on the show today, they're physicians. They know what they're talking about. They have a right to be able to, speak to the uses of it, the side effects of it, why not, all of that. But I think for general population who don't know, who haven't done the research, who are just taking information from TikTok and here and there, I don't know why there's so much conversation, so much debate, and so much hate on something that they know so little about.
There's a class dimension, right? There's some costs associated, so Hollywood celebrities can afford it, and not everybody else can. I listen to Howard Stern, and he's mad right now because he says, like, I spent my whole life working out and watching what I eat to be skinny, and now, all these people are just taking a pill or a jab and getting skinny. There's two things that I'm going to put to the panel for sure, amongst the other things. One is I'm going to say maybe three things. One is I'm going to say, how can you judge if something is safe if it hasn't been around that long? Literally as a weight loss drug for weight loss, the clinical trials were like 3 or 4 years ago.
Right.
So how do we judge? What are the boundaries you set around who you will prescribe this to? If a person who's not obese and wants to lose a couple pounds to get out on the beach comes to you, are you,
Right.
And the third thing is, from what I understand, I'm going to have to put this to them, but Ozempic doesn't, if you stop using it, it stops working, and you may gain the weight back,
right,
fully or more. So then,
what's the point?
You're prescribing something that you're going to be on for life.
Can you be on it for life?
Well,
is it a medication? I thought it was like.
Well, if you can't go off it without gaining the weight back, I guess you do. Yeah.
I'm excited to hear about that answer.
Yeah. So that's coming up. Exciting. Anything else you want to say before we're going to talk on the back end?
I want to hear what the doctors have to say, and then we can talk about it. But I'm interested to hear about that last point. Actually, I thought it was the type of medication that you take for some time, and then you're supposed to like lower your dose and come off of it and things like that.
I think that's what you're supposed to do.
Oh, okay.
But it can contribute to something called weight cycling, which is that as soon as you go off it, you balloon back, or you go back, and then you have to go back on it, and so.
So where's the miracle in that?
Well, yeah, then it's just a crash fad diet, right?
Yeah.
So, let's see what the doctors have to say.
Let's hear it.
We'll talk to you on the other side.
Yes.
Let's get to the great Ozempic debate. All right, let's get to our feature debate. Is Ozempic a new wonder drug that is changing the world, or an epidemic with dangerous consequences? Do doctors always know best? As you likely know, Ozempic, an anti-diabetic drug known generically as semaglutide, has received much media attention in recent years. Although the medication was developed for use in patients with diabetes, celebrities and influencers flaunt dramatic weight loss with its off-label use. And unsurprisingly, there are now many stories of physicians being liberal in prescribing this seemingly magical drug when faced with patients' weight gain concerns. Not everyone is on board, though. Just an unscientific survey of a number of friends and acquaintances I have who are in the medical profession has yielded a wide variety of responses that were often quite contradictory. So is Ozempic a magic pill for weight loss, or an untested new panacea reflective of an ever-shifting aggressive diet culture where slimming down is the one-size-fits-all medical goal? And where do Iranians fit into all of this with their concerns about appearance and perfect bodies? Well, in a little bit, I'll be joined by an Iranian-Canadian endocrinologist here in the Roqe studio who has some concerns about Ozempic to share with us. But first, two of our favorite returning guests who are both very popular, both doctors, albeit in different types of fields, and both practicing in the United States. She is a licensed board-certified naturopathic medical doctor specializing in integrative functional medicine for women. She's also a fitness instructor, yoga and meditation practitioner, and Persian Zumba coach. She actively shares her knowledge and insights through various platforms like Instagram and YouTube. Dr. Afrouz Demeri joins me from Southern California. Hello.
Hi, nice to be here.
Nice to have you back on the show. And he is an Iranian-American doctor who came to international fame and social media stardom as an essential medical voice during the COVID pandemic for Iranians around the world, especially those inside Iran. He is the chief of internal medicine at Clifton Springs Hospital in New York. Dr. Kayvon Mirhadi. Dr. K joins us from New York. Hello, sir.
Hi, Gian. Hi, Dr. Afrouz. Thanks for having me.
I'm thrilled to have you both on. Let's get into this. Before we actually get into the conversation, and not to alarm either of you, but as I said in the introduction, we asked a few doctors, including some people that we know, to be part of this episode, and they expressed some concern about going on the record about Ozempic, particularly those who did not think Ozempic is necessarily the magical answer to all. They had trepidation about the idea of publicly coming out against Ozempic. Just as a sidebar before we start the conversation, does it surprise you or not surprise you that I got that kind of reaction? Afrouz?
No, I used to be one of them. And I actually had posts up in just during COVID, and that I actually took down because of so much hate mail and smear campaigns and all the messages I got from my own colleagues. And so I realized I have to kind of keep this on the down low, and I need way more evidence. I need more patience. I need to wait. And so I completely understand. And I think this is the first time actually I'm talking about it. So when you asked me, I was like, it's time.
Dr. K?
I would agree. I think, there's a lot of unknowns still. And the hype is definitely it's definitely overhyped by the media. But it's not something I would be against. It's definitely, it has enough validated research behind it, and it's part of guideline, like in American Diabetes Association, it's like first line injectable to use Ozempic. So once something goes into like a guideline from like the medical society, they usually, have enough valid, strong research behind it to recommend it. But I have my reservations about it too.
But Kayvon, the trepidation was actually, there was one doctor who was actually, I thought very eloquently making the case to me of why she really doesn't think this is a good thing. And she was worried that she'll be seen as somehow throwing other doctors under the bus, but even more so, and this, she kind of said something about funding and how it's sort of high stakes to come out against these things, which sounded very, Big Brother-ish almost, Is there some truth to that?
Definitely there is with Ozempic, but you look at the history of this drug, it's been around for over 20 plus years. If you look at the mechanism of its action and talk to endocrinologists, especially the older ones in the field, they've been using it for many years, and they know the side effects, and there was not as much push to get this into the social media. I think it naturally went into that direction because weight loss is like such a popular thing and started on TikTok. I think the fear that I have is um, the the general use of individuals that don't need it just because they want to get that summer. It's like any drug, it has side effects. It has an indication to use it. It has side effects that patients have to be aware of.
Okay,
But it's not something that I feel like it's been, there was pharmaceutical money put, so much contributed to it so that doctors are prescribing it without knowing the harms that comes with it.
Okay. Let me get to the let me get into this by just way of getting some wisdom from you guys. If I have this correct, semaglutide, which was the given has the given brand name Ozempic, is a drug that emerged kind of in the last decade, like last 20 years, first and foremost as an anti-diabetic medication used to treat type 2 diabetes. Afterwards, what was your first experience or awareness around it for those purposes, not the weight loss?
So actually, Ozempic semaglutide's only been approved for diabetes. That's what it's used for. But I actually didn't see many of my existing patients who would walk into my office with that. Mine was Victoza, Saxenda. I've had older patients who've been on the first GLP-1 agonist, exenatide, also known as Byetta. So I was used to GLP-1 agonists. I think when Oprah kind of made the announcement and then we saw all these Hollywood stars, that's when a lot of maybe the mainstream people became aware of it. But like Dr. K said,
as a weight loss, for weight loss, not for diabetes, right?
Yes, a lot of my diabetic patients or obese patients who are also diabetic and metabolic syndrome, they are looking for weight loss, But yes, people have been on these. So that was my first sort of acquaintance, I guess, with it. It's been around. And since I practice endocrinology and this has been in the field. I will add that most of my patients didn't love the feeling of it. And I'll talk about how I use it and how I think we should be studying these in much lower dosages and not jacking up the receptors by doubling it every 4 weeks and giving people such high standards that's causing a lot of these side effects. I think as a naturopathic doctor, typically people come to me to wean them off drugs, or not for me to prescribe drugs. So it's probably surprising for people to hear. And I know this wasn't your question, but I'm going to answer it anyways, is I'm actually for it, but I use it in much smaller dosages. And then it's got a goal of coming off it, and only if they do other things with it. So it's not a magic pill. It shouldn't be used the way it's been used, which is to get these pens, jack up, make people sick, make them vomit, make them nauseous, and make them lose a lot of weight quickly. People who don't need it, people who are not diabetic, people who are not obese are using this incorrectly. Okay. And I think that's...
Let me get to a bunch of that. You said a lot. I mean, first of all, when you say it's been around for a long time, I know the semaglutide has, but I mean, in terms of Ozempic for weight loss, like the clinical trials, unless my research is wrong, were only 3.5 years ago. So, I mean, this is very, very new as an anti-obesity treatment for weight loss. Dr. K, when you first heard about this for those purposes, for the weight loss purpose, did you have any concerns? I mean, what goes through an experienced doctor's mind when they hear there's this new thing that everybody is saying is the new, again, magic pill for weight loss?
So yeah, it's not like a new thing. Like exenatide is another type of GLP-1 agonist that's been around since 2003 or 2005, and it's been used by endocrinologists, for their diabetic patients, as Dr. Afrouz was saying. One advantage of using GLP-1 agonists is weight loss, because it really just kind of decreases your appetite, taste, for food, decreases your gut motility. The thing with semaglutide, which is Ozempic, it's this, mechanism of action is the same, but they worked on the drug to make it like longer acting. As Dr. Afrouz said, it is higher dose than normally used. So the higher you go on the dose of a drug, the more effect you get. but it comes with a price, with the side effects and everything. And they saw that there was weight loss with semaglutide Ozempic when they were using it for diabetics. So then they reformulated it even at a higher dose, a little bit higher dose as Wegovy, which is really what the FDA approved for the weight loss. But you're right, the semaglutide itself, it's only been the trials kind of presented since 2019, 2017 to 2019. But the drug itself, like the family that it comes from, has been around for over 20 some odd years. So we're pretty familiar with this. It's not like a magic pill that was discovered 3 years ago and now everybody's on it. They've been using GLP-1 agonists since like early 2000s.
Can you explain for those of us who aren't doctors like you guys? I mean, one of the people I spoke to who had trepidation about Ozempic, one of her concerns, as she's a doctor, was that it's not FDA approved. But as you say, Wegovy is FDA approved for weight loss. These are discrepancies that I don't understand. What's the difference?
So the FDA approval is when they do a research, they do it, on an outcome. So the outcome that Ozempic was focused on was on blood glucose and diabetes. So its approval was for diabetic management, but a lot of like the trials show weight loss from the Ozempic trial. So then a lot of doctors use it as off-label for weight loss, but it still has an indication for patients that have diabetics. Then they put out Wegovy, which they use like a little bit higher dose of the semaglutide, and that got FDA approval for weight loss. You could prescribe somebody Wegovy for weight loss only, but it's really the same drug at a slightly higher dose.
So the higher dose is approved, and the lower dose is not.
They're both approved. It's just the indication of their approval.
I see.
So Ozempic, the research was done for diabetics and blood glucose, but they saw with the weight loss. So really, they weren't really seeking just for a weight loss pill, weight loss injectable. So Wegovy is the same thing. It's just a different name, but it's like 0.4 milligrams higher dose, and they saw better results with weight loss. So they seeked FDA approval for the weight loss purpose. You see what I'm saying? It's like the same thing, but it goes based on the trials and really what your indications are and what you're looking for.
So it's a bit of a technicality to say that Ozempic is not FDA approved.
Yeah, this thing is FDA approved. It's in most guidelines. It's first injectable for diabetic patients management that have failed, the conventional things like metformin and
I mean, for the sake of this conversation, and when I say the Ozempic debate, I tried to do my research as much as possible. I didn't see any great debate or confrontation or dispute around Ozempic when it comes to type 2 diabetes. I mean, it seems like there was a universal sense that this is a good drug for treatment in that area. So what we're talking about today is in the area of weight loss and how it may be used or misused. In that realm, Afrooz, let's start with the positive. You said you've prescribed it and sometimes and very successfully. So what are the great benefits you've seen with Ozempic when it comes to weight loss?
Well, before I answer that, if I can just add, and this is really important because I didn't know this. I always thought that when I was a student that a medication has to be approved. And I wasn't aware of off-label use until I went into practice. And being at a university, being a director, it's all evidence-based. And then I realized, wow, us doctors or my colleagues, more medical doctors, use off-label drugs all the time. Like aspirin, for example, is actually off-label use for cardiovascular prophylactic. Beta blockers, sleeping pills, Viagra, you name it. Many drugs are used off-label. But I feel like Ozempic has gotten such a bad rep for being used off-label, and even doctors are upset. And I'm having these debates with them going, you're the one using off-label drugs all the time and putting patients on, these for life. And if this is benefiting, and this is how I use it, with other things that are important in diabetes. My patients with diabetes love them to death, but it took them a while to get there. Now, some of my patients are on medications that causes their blood sugar to go up. And it's not like they're eating junk food all day and not moving. That's a different category. This can be very helpful for those. But how I like to use it is say to my metabolically fit patients. Those are my women who are premenopausal, perimenopausal, menopausal, who now have truncal obesity, who now have visceral fat when they didn't. You know, they looked fit like I was, and then now they're in their 40s and they're like, I can't get rid of this belly fat. So they don't fall into the category to be given Ozempic. They're not diabetic. Maybe they're a little bit insulin resistant, but not enough that the insurance would cover it. And so they were coming to me microdosing. And I was like, how are you getting this? But when there was a shortage, this is where compounding pharmacies are allowed to start making this patent drug, which you normally can't. If something's patented, you can't just go and make the same thing. So they would make it differently. And this is where a lot of debate would come in, because it's not FDA approved. It's not that pen that they can use. This is something compounded by a pharmacist, and you don't know necessarily what's in there. So this is where I think in my world, which I know most medical doctors and endocrinologists, they have to follow guidelines. They can't use it that way. I have. And this is why I've taken 2 or 3 years before I can come out and say, now I have hundreds of patients that I have microdosed. And the effects I'm seeing is not just weight loss. I think this is such a profound medication. And for me to say that, I think that's huge, because I'm not usually the one to prescribe. But the neuroprotective, immune modulating, cardiovascular, I mean, the amount of people that'll come to me and say, like, my brain is working again. Like, I used to have ADHD. I used to not be able to like remember things. And cognitively, I've got my brain back. And so now we're starting to see that it does so much for the endothelial lining of the heart. You know, there was a select study that looked at people in their 40s, my age, who were not diabetic, and they had a 20% decreased risk of stroke. Now, the study was...
That does sound like a wonder drug. That does sound like... Go ahead.
Got to get else in. You got to get your movement in. You got to be strength training. You got to be getting your protein in. It can't be used the way it is, because losing weight that quickly puts pressure on the pancreas. Losing weight that quickly, what's going to happen?
Okay, so let me work through the questions, and then, because you give me the whole kit and caboodle there, but let me I want to work through. I mean, that sounds like a wonderful. Actually, what you just did there is give a real validation of Ozempic, and I think even in your personal journey around it, and discovering what it can do, and Dr. K, feel free at some point if you want to do that as well in terms of talking about the benefits of it. I want to work through, for the sake of this debate, because I think this will be the most helpful for people who are watching, some of the concerns that I've tried to put together in terms of what I've seen out there, and you guys can either suggest that they're to refute them, or suggest that there's something there to these. One of them is that especially when it comes to type 2 diabetes or obesity associated with eating disorders, especially binge eating disorders, being prescribed Ozempic or Wegovy may assist in weight loss for those who are in the higher weight body, but it won't address the underlying factors that can lead to binge eating disorders. Can either of you want to speak to that?
I think that's like a pattern that develops throughout your life with everything that happens. It's not just one problem you're tackling. Usually, like, it's way more complex than that. Like, just to prescribe Ozempic to fix binge eating disorder, that comes from so many things, like behavioral events in your life and psychological things that are involved in it. It's not just as easy as just putting it like that you can just prescribe. It sounds like a wonder drug, but it's really not. And it has like a specific indication. It has a lot of side effects. And I think we're all going to come to the same point that it's a lot of misinformation about it out there. And thinking like that is one of them. Like, I have binge eating disorder, Ozempic is right for me, without considering that really it's not as easy. It's not easily curing like psychological disorders like that. It has some, and all the benefits that Dr. Afrouz was talking about, like there's studies about cardiovascular benefit, decreasing dementia risk or whatnot. We're talking marginal here. Like, we're not talking a medication that's going to take away Alzheimer's from the population. and the side effects that it comes with is something we need to consider. So I would say a lot of these come from like misinformed posts and viral things from the internet that like, oh, hey, you have this disorder, Ozempic's your cure. You know, it's not like that at all.
There's another concern. This one actually really speaks to me because I tend to worry about having an addictive personality or a ritualized personality. There's a concern that Ozempic only works when you are on it, and that this medication may also perpetuate weight cycling, since research shows that has shown that stopping use of this tends to result in regaining the lost weight. Have you witnessed that, Afruz?
Yes, absolutely. Especially the way it's prescribed. Now, there is studies showing that if you do take on exercise and you do strength training and maintain muscle, it can be more beneficial when you come off it. But again, you have to have a long-term plan. What is the plan? Is the plan to just go on this to lose the weight? Then what? Is it forever? No, it can't be used that way. It does have, like Dr. K said, side effects. That's why that's not how I recommend people use it. Going back to binge eating, of course, there's no drug that can cure anything like that. You know, and everything has its effect. But what I love about this is that GLP-1, this is something, a peptide, a hormone that actually your own body makes. So most people don't realize there's a lot of research now coming up with genes and people who have genetic mutations where they actually are GLP-1 deficient. And so this is what always intrigued me, is like I was totally against prescribing it myself because I'm all about lifestyle first. Why is someone binge eating? What is this addiction, this dopaminergic high that we want? We want things quickly. We want it now. Their food addiction, sex addiction, gambling addiction, shopping addiction. We all have it. Why judge and demonize anything that is to help that person? I think that's the number one thing I want people listening to know, is that there shouldn't be any shame. I have so many patients who are so ashamed to even admit to me that they took it or they were on it, and their doctors are getting upset at them. And we shouldn't be demonizing or shaming, especially in our Persian culture where everything is like Kolani go off, and that's the first thing that's got to go. Is no, it's not bad. But it's why are you using it?
But in terms of the Dr. K, in terms of the weight cycling, and listen, I mean, I'm asking, I'm trying to learn. If somebody is taking this drug and it's really, really working out for them and it's changed their life, who am I to complain? I'm asking you your thoughts around this. If it's the case that it only works when you're on it, and you're going to balloon back or gain the weight back if you go off it, then how is it any different from all of those fad diets that we've known since we were kids? You know, that's the banana diet, and then the one where you're only supposed to eat protein, and then the other one where you're not supposed to eat eggs. I mean, what is the how is this any different if there's a dependency of having to stay on this drug?
So people don't like to cut out those foods that they like, they're just so ingrained in their habit of like eating chips and not eating carrots and not, eating McDonald's and not eating their daily fruits and veggies. So they want to continue that. It's just most of the diets that we start, their success is not very long, to be honest. If you look at the population, unless you have a coach, unless you're so committed and psychologically and behaviorally you're there, it's not going to work. With injecting yourself once a week, people feel like they found this magic solution where they can continue eating their kebab kubide with rice and just continue losing weight. And we see that and that's why it's very popular. Like they've done head-to-head studies with Ozempic or Wegovy and other weight loss drugs. And this outperformed all of them. And I don't know if we're going to talk about Mounjaro, but Mounjaro is the next level that outperformed Ozempic. So now I get a lot of messages on my page, like, tell me about Mounjaro. That's the one I want. So people are just looking for not changing their lifestyle, their habits that are already putting them into where they are right now, and just fixing it with an injection. And that's not how things work. And losing this kind of weight, again, I'm a proponent of the drug for individuals that have done lifestyle changes and are still, they have comorbidities or diabetes, and it comes from a physician. But just to buy it off label or buy it off the streets or go to Mexico and pick up the oral version of it and start taking, as I know a lot of people are doing it, it's not healthy for your body. You're losing a lot of fat, but you're losing muscle tissue with it. And it's all going to come back if you stop injections. I know people that take it for a week and they get some side effect, like they're just nauseous or they're dizzy, they stop. So it's you're taking the risk of taking this drug and all the side effects, and at the same time you're not continuing it. You have to make some major lifestyle changes to maintain your weight, not just start this drug.
Dr. Afros?
The way I do it, and not everyone has access to someone like a coach, a fitness trainer, a dietitian who's going to work with you, is ask your endocrinologist or a prescriber if they're willing to work with you to stay more at the lower dose and have an off cycle. And that is what happens, because when you're on it, you're not going to want to eat that much. And like Dr. K said, whatever you used to eat a lot of, you're going to eat probably the same thing that led you to where you are, but just less of it. And that's not a very healthy state. So you're going to be in a caloric deficit. You're going to lose muscle. And then if you now come off it, let's say for 2 weeks, that is when you start lifting heavy shit. That's when you start upping your protein and changing. That's the time where you realize that food noise that you used to have every day of what am I going to eat, binging, eating, suppressing your emotions because that dopamine rush of that getting to the McDonald's helped you. Now you realize you do get a glimpse of, oh my God, I haven't thought about food all day. I'm not interested in even other addictions that I've had. I mean, I've had people that used to drink every night, a glass of wine, 2 glasses of wine. They don't have that interest. The addictions do lessen, but it's not a quick fix. It's going to come back. But at least in that time, if you have the goal to work on it and see your therapist, see your psychologist, do the work, get your trainer. And that's what I always say to my patients is we got to have a plan. We are not just going on this and because I'm telling you, it's not going to work. If anything, going to just waste a lot of money and my time, and we want success. What are our short-term goals? So I like to cycle people on and off. They use that off time. Now that they're motivated, they have hope. It's hard for obese diabetic patients to come to my Zumba class. It hurts their knee. They're like, Dr. Z, I know what to eat. I know I need to exercise, but I can't. I'm stuck. So this can just move the needle up a bit with the right direction and guidance, but that all of the other things have to be there.
You talked about Dr. Afriz, you just talked about the fact that not everybody can afford the coach and the trainer and all of that. Not everybody can afford the drug. Dr. K, you actually did a post about the costs of Ozempic, and we tend to, if you're well off in Orange County or in the north of Toronto and you can afford these things each week, great, but it's kind of a discriminating drug based on its costs as well, is it not, Dr. K?
Yeah, drugs in general are so expensive. People can't even afford their insulin or blood thinners. But yeah, let alone to splurge on such a thing where you could probably achieve by just exercising more and eating less and calorie counting. You got to be well off to do so. Most insurances, I think there's some discount programs, but usually you're looking at 800 to 1,000 something US dollars a month. If I'm right, like I don't prescribe because I work inpatient, but Dr. Fus might know there's like high copay. And again, this is a lifelong drug, right? Like this is something, would you pay membership to any, account, $1,000 a month? Like I'm kind of struggling with my Netflix membership here. Am I going to be enrolling in such a thing? And if it's really working for you, you have the right indication, you have the right follow-ups, and you don't have the major side effects, and you accept those risks, like long-term risks, which are, not life-threatening. So there is some risk of like medullary thyroid cancer and, that are seen in rats and like, lab research, not in the actual population. If you accept those risks, you should continue under the guidance of your physician. But if you're really going out to buy this off the black market, it's a bad idea.
Can I just, when you've mentioned a few times risks and side effects, can I list some of them and you can tell me whether this is normal, whether all drugs have these kind of serious side effects of Ozempic include, and this is a truncated list. There was a much longer list. I edited this list. Include thyroid tumors, pancreatitis, changes in vision, hypoglycemia, gallbladder issues, kidney failure, and cancer.
So you
Is
gotta be
that
careful.
normal?
You're talking about side effects, thyroid tumors. Maybe scaring some people here. So majority of side effects are gastrointestinal, nausea, vomiting, feeling full, abdominal pain. Um, then we go into side effects that are seen in a very small portion of the population, which are things like, I think we spoke about it earlier, like stress on your body, like gallbladder, your pancreas. So you get inflammation around that. There has been rare cases of um, medullary thyroid cancers seen in laboratory stage, not in populations, not in big studies like the SUSTAIN. There was not a single participant reporting that I got thyroid cancer from this. Or there was some earlier reports about diabetic retinopathy and people going blind with these drugs. These are observational studies and still very early, and it wasn't seen in big trials, the randomized control trials. So I don't want people to be scared if they're on it and say, "Oh, I heard that this causes thyroid cancer. I'm going to throw this away." Um, but that's the thing. You start anything, any medication, you take the COVID vaccine, there's side effects. You got to be aware of those things, you know. Um, but there's a time and there's an indication for doing so. Not just, I get messages on my account from very skinny people looking for this. Like, I'm not kidding. They're like, I just need to lose an extra like 10 kilos. I'm like, this is not for you.
I want to get to that. I want to get to that. Before I get to that, though, because I want to learn where your parameters are in terms of when you would prescribe and when you wouldn't. But don't answer that just yet, Dr. Afriz. I wanted to ask you specifically about Ozempic face. Is it a thing? Is it actually a thing?
Yeah, if you lose weight with anything, even if you starve yourself quickly, absolutely. But I'm not interested in that. I just want to comment, you better not cut this part out, on side effects. I have not had one patient with pancreatitis or all the things that are listed that scare everybody because it is just used too high. And that is what I want people to know. If you're on it long term and you are not taking care of your health and you are going to the max, of course it's going to have that effect when there's that much insulin and your beta cells from your pancreas are storming with all this. There's going to be consequences. So don't look at that. I mean, rats get medullary cancer, thyroid cancer normally without this stuff. So I think there's a lot of misinformation and scare. You have to look at the risk of not doing something and being inflamed and metabolically obese and high glucose, and what's that going to do to you? And look at the benefits of what is the risk if I don't do anything, in the patient. I'm not talking about the skinny girl who wants to lose a few pounds here and there. I'm talking about the people that really have an issue. And I know in the US, 97% of the US is metabolically in crisis. I mean, in 2045, we're going to have men with zero sperm. And one of my things is fertility. That's what I see is this has helped my patients with PCOS, with men who are, thinking like, oh, it's not me. And half of miscarriages are men. So this is a much broader place of use. And I hope that we get more research on this, and we're going to. But I think to scare people with all these side effects is not right.
Well, that's why I asked whether that was normal or not. By the way, there's no intention to edit any of this out. But I am surprised that you say that you don't care about Ozempic face, and not because I'm care about necessarily the aesthetic of it, but it suggests to me the idea is that you get this drawn hangdog face because you lose too much weight. For me, that's an indicator that something unnatural is happening to one's body, is it not?
Yeah, but that if anybody doesn't eat for 16 weeks, you put anyone in a kind of a mini starvation diet, they're going to lose weight. I don't know why everyone is so obsessed about this Ozempic face.
Well, not eating for 16 weeks wouldn't be a good idea, would it?
No, and that's why I'm saying we shouldn't be using it the way it's been used. It's just too fast, too much, it's too quick. I think a little bit of weight loss so we can maintain it, understand our psychological relationship with food. Are we moving? Are we getting sunlight? Are we sleeping? Are we eating? Are we getting a diverse amount of vegetables and colors? This is where the conversation needs to change. So yes, I agree with this endocrinologist that's coming on saying I'm not a fan of it, I'm happy to hear that, because we can't just prescribe this and say, okay, off you go. I'll see you in 4 weeks for your next dose. How are you doing? Are you vomiting? Are you nauseous? That is a sign. As soon as someone has a symptom that it's too much, that's the body saying it's not working. And we need to listen to that.
It's tough because we do live in a quick fix culture, and we know that Iranians are not immune to the quick fixes. Dr. K, I wanted to ask you what you've noticed in the Iranian community about the interest in Ozempic. Does it track any different from other patients?
Are you talking about the Iranian community inside Iran that I'm in contact with through my, well, oh yeah, it's like the next thing. So I get a lot of requests about this drug, not to prescribe it to them because I have no like communication in that scenario, but a lot of like, should I go on this drug? My grandma had pancreatitis. Can I be on it? So first of all, like there's not enough information out there. So I'm glad that you're doing this. But yeah, I think us as a culture of Iranians, we're looking for quick answers, which I've noticed the last several years I've been active in this community is we want quick fixes for our smoking habits, our overweight issues, our diabetes, our demented family members. Just give me a pill to fix it, you know? And Ozempic did come out as this kind of, it was marketed like that, like the wonder thing. With you know, in US you have commercials for drugs too. It's like you take it, you're fine, and then at the end they list all the side effects, just for legal purposes. But that attracts a certain type of person, you know, because we're skeptical about some things, but usually if we see something that's like a magical wonder drug, we all go to it. So we're like, okay, we should all just take this. We're going to be fine for the rest of our lives. I don't know. It's that like security blanket that we all like Iranians looking for. But it's the problem is our community is also filled with a lot of misinformation about this drug. There's
a different version of it in Iran. Something that starts with L. Did I hear that correctly?
Liraglutide is the one that's more commonly used, like Victoza. Like so how these drugs kind of like flow through the world is like first they come in North America, and then the older versions of all these drugs are in like, you know, Iran and other countries, and eventually they get there. But right now I think there's Ozempic in Iran. And Mounjaro too, because I've had patients that are like getting Mounjaro. But where it's coming from is black market. So it goes back to the earlier thing, like off-label prescriptions, people getting it from, like, are you really sure this is the drug you're getting? Or like compounded pharmacists making it from somewhere, they're getting this shipment. So you're really not sure if you're getting the correct drug or the drug dose. So I don't know what they're getting there.
Dr. Afriz, whether inside Iran or in the diaspora, are there any tendencies that you've noticed of the Iranian community that are germane to this conversation around Ozempic?
I think two things I notice is just friends and family. I can tell when someone's taken it, you know, with the sudden change in their looks, and they've been talking to me about weight loss for years, and then all of a sudden in a month it's like, oh wow, what's happened? And oh, you know, I've been intermittent fasting. And so one is just the dishonesty and the shame, and I want to change that because that's gotta change. But two, I don't want to push my mom under the bus. She's the most common text I get is, you know, Amme Folani is got MS or Parkinson's to Iran, what should they take? And it's like that kind of questioning of just give me the answer. And I'm like, Mom, it doesn't work that way. You know, it's not like I can say, but as actor, you know, and it's going to cure. So, but that way of thinking, it's not like, wait, did it take me this many years to get here? And it might take another 40 to kind of figure out how I got here. Like that questioning isn't quite there. I find with my other patients, I find Iranians do come in kind of with this expectation that you are going to fix me and like you have an answer for me. Especially the older crowd, you know, like diet, lifestyle, stress, what's been causing your relationship toxicity. It's like, no,
the thing is like, we're born in a culture where you get like a sore throat, you go to the doctor, they give you dexamethasone and penicillin in your butt, they send you home, you're like, I feel great. So that's really that's their view of like physicians. So that just gives you that adrenaline rush that you feel. And then here you're like, hey, this could be that, this could be that. You're like, دکتر بلد نیست. Like he doesn't know what he's talking about. I'm just gonna go to another doctor.
It's so true. I talk about this with my staff all the time, the Roqe media team, because some of them are, have come from Iran within the last 5 years and stuff. And somebody gets a sniffle and they're like, "Boro doctor diye." And you're like, it's kind of not what we do here. We let it gestate for a while and figure out if it's going to get worse. And but the quick fix is something that is, I guess, taught in Iran or amongst Iranians.
Yeah.
Yeah, I mean, look at our political world right now. We're looking for a quick fix.
Wow.
Something that can fix
You went
everything.
there. You went there. We were skating. We were skating by. Listen, before I let you guys go, so let me. And I didn't actually know exactly what you guys were going to say today, and I'm not surprised that you're both, knowing you're both nuanced thinkers. I didn't anticipate you were going to say anything radical in terms of wildly supporting or hating on Ozempic. But I am curious, given that you've both said that there have to be some guardrails around how and when we prescribe this, how you determine those things. So let me give you a scenario. Even if you think it's good for weight loss, would you prescribe it to, let's say, a 22-year-old woman comes into your clinic, either of you, and says they want to lose 20 pounds? Do you prescribe Afrooz?
I would, but we have to have the discussion, and only I would because I have experience doing this now for 3 years, microdosing. I would not recommend they start. I would probably use tirzepatide, Mounjaro. That's my favorite. I prefer that over semaglutide. It's much better for visceral fat. But the pillars of health for me as a naturopathic doctor have to be there. Obviously, I would look at everything, and this would go into one of the many things that we would do. But I have helped because.
So I mean, if I can push back on that, so this is not an obese person, right? This is somebody who wants to lose 20 pounds. Doesn't that person become a prime candidate for, hey, why don't you change your lifestyle, exercise, food, et cetera, diet, rather than go on this injection?
Of course, that's what I mean. The pillars have to be there. So no one gets this as the first therapy. It's an adjunct therapy that has to go with the conversations and getting to know your patients. At 22, how did you gain that 20 pounds? Right? So these are the people that are going to maybe become diabetic, and my medicine is preventative. It's let's prevent. So to wait and say, well, you're not diabetic yet, so come back, in 20 years when you're 40 and diabetic, then I will give you X, Y, and Z. This is the kind of debates I'm having with my friends and colleagues. It's why is it okay to treat people who are really sick and not help people early? Because they're going to go to Mexico and they do. First of all, the oral doesn't really work, in my opinion, in my practice. And then now their gut
you mean the pill that there's a new Wegovy pill, right?
Experience with the subcutaneous.
Yeah.
And now their gut's a mess. They're doing it off-label themselves. They're going online. In the US, pretty much anyone can get it now. And it's for like $200 a month. You can get it, and you kind of check in with this robot that's supposed to be an NP, and you send a picture of yourself, which you can Photoshop. Anybody can get it. I have patients coming in. I've had patients end up in the hospital with pancreatitis because they injected the wrong dose. They don't know what they're doing. So I would rather at least guide them and make sure they're on the right path. So my answer is yes, because I have said no, and I said no for a long time, and then ended up getting a call. Hey, this 40-year-old is hypoglycemic in the hospital with pancreatitis, lipase of like 400. And I'm like, what did they do? Oh, they did 25 mils and that took the wrong dose, because many of the drugs have different dosages.
Kayvon, what do you do in that scenario?
So there's like specific indications that we have to follow because of medical legal issues. With that 22-year-old who's not obese, is she diabetic? There's wiggle room here because Ozempic, the indication is that you can give it to diabetics for glucose control. Wegovy, which is the same drug, a little bit higher dose, there's indications for BMI over 30. For BMI, you just take your weight and divide it by your height in meters squared. Weight in kgs. If that's over 30, you meet the criteria to start Wegovy. If you've tried lifestyle modifications and stuff and it hasn't worked. If it's over 27 BMI, you have a comorbidity like high blood pressure, you have diabetes, then you definitely qualify. So that 22-year-old, if she's a diabetic and she really wants it, you could as a physician prescribe it. Like no one's gonna come fault you for it for diabetic management, and that's really like getting into guidelines. But you have to try other means. I mean, it was always like metformin first, but now metformin is falling out of favors with these GLP-1 agonists. I personally do not like drugs, so even I work in the hospital. I don't start anybody on anybody. Even antibiotics, I stop them after a couple of days because you look at research, there's no indication to start people on drugs unless you really have to. So I always do like, you'll be fine, go exercise, try a diet, but if it comes to a point where their A1C is like 9 or a 10, you've already tried oral diabetic medications. They don't like to be on insulin, or you've tried insulin, they're non-compliant. You feel like they have some insulin left in them. You could try them. I don't see why not.
It's such a pleasure to speak to both of you guys about this. I didn't want to sort of lead with this or throw it in the beginning because I can't validate whether this is all true or not. But one of the people I spoke to, one of the doctors I spoke to in recent days leading up to this, not only who would be in the camp of this is a magic drug, was saying there are so many, and I think, by the way, I think this is why there's skepticism, why somebody like me or a journalist or anybody who's naturally kind of critical thinking or is skeptical of something like Ozempic, because when you hear so many good things about something so quickly, you kind of go, really? So this person was saying this drug is not only working on the weight loss and the diabetes, etc., but that it is curbing addiction in people. So people who, for example, have issues with alcohol addiction are finding that this is really helping. So it's I mean, this is where it turns into sort of a cure-all. But have you heard about that in terms of addiction issues and Ozempic, Afruz?
Absolutely. I mean, I've had a patient I could think of at the top of my head who we have been struggling with smoking. Actually, I have a gentleman who just recently had to get divorced because of alcohol addiction. I have had men with sex addiction, porn addiction. I mean, you name it. I didn't intend to use it and think that that would help, but absolutely working with their therapist during this time when that noise goes down is crucial, because it has actually been shown GLP-1s are not just made in the gut, they're actually made in the brain. And anything that's made in the brain is usually helpful for the brain. And they're finding it in the hypothalamus pituitary axis, which is our dopaminergic, as we said, that dopamine response that we get with alcohol, with something that we become addicted to. So I do see this being researched and used hopefully in the future. Again, microdose, not on such physiologically, bombarding the receptors that we have problems, but using it a less, go slow. And I love to hear when a medical doctor, it's like news, like I can't tell you how happy I am to hear doctors say, I don't like to prescribe meds. That's not the majority. So to use this in situations for addictions where, we are using other really harsh drugs and telling patients, you need to be this on life for life. And they have drastic side effects. So maybe I'm hoping more research can come out on this for psychological health and mental well-being.
Kayvon, last word to you.
Yeah, like 100% I agree with Dr. Afruz. So I think the main thing is, I work in a hospital, so I see a lot of sick people come in and die. And these are people on medications that are taking chronically for the chronic illnesses like heart failure, diabetes. They still come and die. Medications can help you. It's a small percentage of what you really need to feel better and get better. And I always tell them, I'm like, there's no magic drug in the world that's going to take away your cancer, your obesity, your diabetes. It's just going to assist you a little bit. There's no magic antibiotics that's going to cure your infection. If I didn't give you the antibiotics, your immune system, if you have a good immune system, would have taken care of it. I'm just giving you that little boost. So people have to understand that and really think about why are all doctors saying you got to live healthy, don't smoke, don't drink, exercise every day, eat healthy. Because really that's a behavior that most humans don't have inherently because of the life that we live. And that's why we ended up getting all these illnesses. Some things are genetic and there's nothing you can do. But even if you have some genetic predisposition and you live a healthy lifestyle, you're not going to need these things. So like all these guideline directed medical therapy, all these first line, it's good because we have it at our disposal, but it should be kind of last kind of resource. If somebody has tried the diet, has tried the exercise, has tried seeing a therapist for their food addiction and still didn't work, then we can use it. That's really my recommendation to all my patients in the hospital. Like, try to live a healthy lifestyle. Don't ask for medications. Go have a cigarette outside and go drink like this much alcohol tonight and expect to get better. It's not going to happen.
So, Dr. K, can I say something to that? That I agree with you. However, there's medications and there's things that are made by our body that if someone is low in, let's say someone is insulin deficient, their pancreas isn't working, a doctor is going to prescribe insulin. Let's say someone's completely hypothyroid from years of Hashimoto's and now they're hypothyroid. We give them thyroid hormone. Someone's hot flashes, their menopausal estrogen is like 1 or 0. We may prescribe estrogen. I am hypothesizing that in 20 years, we'll be able to look at my patients who have been anorexic for 20 years and their gut lining, or let's say someone who's been given antibiotics for 20 years for ear infections and their gut microbiome is so messed up. And now we're seeing research that their GLP-1 is low. We don't have a way to measure this yet in a blood test, but there is a lot of doctors who've been using this saying, if someone is GLP-1 deficient, like growth hormone deficient, are we going to just say, this is a medication that has side effects, we're not going to use it? Or just like any other hormone that your body naturally makes or peptide, if it is low, could we change the conversation to not talk about it the way it's been used? Because right now, this is a natural thing your body makes, except, these medications got some lipids added to it to make it last longer, have a 1-week half-life. But what if we used it the similar way that an endocrinologist replaces something that's low in the body that could actually physiologically go back up to where it should be, not so high? And that's what I'm trying to get people to talk about, at least us doctors, researchers. We need to start looking at this differently because it's going to be around. If all the stars and Oprahs in the world are using it, for us doctors to be, bashing it down, I'm interested in the research. Let's look and see if we can find ways to look at GLP-1 differently.
All right.
Yeah, I wouldn't be surprised down the line if there's other major indications for this. But I'm more pessimistic working in the hospital and seeing patients come in despite all these interventions. So to me, and I always trace it back to how they live their life.
Yeah.
The patients that I see in their late 90s and hundreds coming in for a UTI, they were farmers. They never smoked. They never drank. They woke up 4 a.m. doing farming. These are the patients that live a long life. People with high stress life and environment, they're coming in their 40s with diabetes and amputated legs. And I really do hope there's more research done on this, which I'm sure, to see, to what extent we can use this type of drug like GLP-1 agonists and GIPs. But I just really would advocate for people not to do this on their own. Talk to a physician and just keep following up with them.
Dr. Damari, Dr. K, there's a reason why you're a couple of our favorites. Thank you so much to both of you, and to be continued. Thank you for this.
Thank you.
Thank you.
That's Dr. Afrouz Damari in California, Dr. Keyvan Mirhadi in New York. All right, now we turn to, in our studio, Dr. Jaleh Hassanloo. She is an Iranian-Canadian endocrinologist and internist at North York General Hospital in Toronto. She's a graduate of McGill University in Montreal. Dr. Hassanloo completed her medical education in Iran before joining the World Health Organization as a medical officer, leveraging her multilingual abilities in English, French, Farsi to make an impact on global health. Her passion for advancing in her field led her to further specialize in adult endocrinology and metabolic disorders, completing a fellowship in this critical area of medicine. Now based in Toronto, Dr. Hassanloo runs her own practice where she treats a wide variety of hormonal and metabolic conditions while also working in hospital settings to provide comprehensive care. Welcome, Dr. Jaleh Hassanloo.
Hi, Jean.
Thank you for being here.
Thank you for having me.
So we've just had this interesting discussion as you were listening in on with Dr. Afrouz and Dr. K. And I started, as you would know, saying that it's interesting to me that some doctors, those I canvassed over the weekend at least, have some trepidation about wanting to talk about Ozempic at all publicly. Does that surprise you?
Not really. So nowadays, fever of Ozempic is everywhere, and there has been some controversies about it because some people, they believe this is just a magic bullet. So they just have to they see the solution of everything for their weight loss management, the weight management, in Ozempic or the other drugs from the same group, GLP-1 agonist. So which they are in fact called glucagon-like peptides. So for the sake of conversation, I would just say GLP-1s. I believe that there has been quite controversies around this because this medication and the similar medication has been misused by some, I would say maybe patients. There should be, this medication is a strong tool, but it should be in the hand of professionals and should be monitored and should be prescribed if the patient actually meets the eligibility criteria. We should consider that this medication was originally provided for the diabetic patients, and it's actually doing very well for the diabetes patients. For the type 2 diabetes
but
patients.
It's become the weight loss drug.
That was one of the other effects that now being used off label. There are other positive points in GLP-1 we should consider, such as cardiovascular benefits. There's several studies nowadays going on that, and they have a great cardiorenal profile, and they could be also effective in the management of fatty liver, non-alcoholic fatty liver. There are other studies, ongoing studies as a neuroprotective agent, such as Alzheimer. So we cannot, it's not that simple just to say, oh, it's a bad drug or it's a good drug. It really depends how we use it and how, for which patients we actually.
But can you remember any drug in recent history that has had ascribed to it this much positivity that it's, I mean, as we were just ending the interview there, I was saying, you know, it can cure alcoholism, the addiction. It can, I mean, it does at times, the way people talk about it, sound like a magic pill. And then of course, skeptics like myself go, well, how is that possible? And one of the things that people have said, which I didn't bring up with Dr. Affers and Dr. K, is that it's hard to know the effects of what a drug is, the effects that a drug is going to have years down the road, right, when it's only been around for a few years. How do we mitigate against that?
Yeah, I agree, actually. So I am going to answer your first question, if there has been other drugs, such as, so I can think of one, sildenafil, Viagra, for example, that when originally Viagra came, it was for the management of high blood pressure and cardiac conditions, but it has been used by the patient for other.
Oh, I didn't know. I thought Viagra was for Viagra. It was for
sildenafil.
Right.
So but if the patient doesn't use it properly, it could be fatal. So there are several. Like I don't have all in right now on the top of my head, but there are several medications that, you know.
But a drug that all the Hollywood celebrities are suddenly taking, I mean, it's definitely in vogue right now, right?
Right.
Which makes it, and you are somebody, your job partly is prescribing this, Ozempic. So have you seen a massive increase in the kind of interest of people coming to you looking for prescriptions?
Absolutely. Yeah, the patient they come and they insist on, like, you know, startups from the scratch and GLP-1 agonists, the whole family, not just Ozempic, Wegovy, Ozempic, Wegovy, Mounjaros, Saxenda, any of those. So the thing is, but I always handpick the patients. They should be screened. We cannot really consider, oh, okay, I'm going to start, like, no matter what, I'm going to start a medication. First of all, in the case of when the patient comes, first of all, if they have a diabetes, okay, if there is an indication for this medication, which there are certain indications such as glycemia level, other medications, of course, the body mass index. etc. But if the patient comes and they come for the off-label use for weight loss only, then we have to see. Fortunately, we live in Canada, which obesity is a part. It has been approved as a disease that being covered by insurance, both public and private. So I would say if the patient meets the criteria by Obesity Canada, the criteria they should have a BMI of over 30 or BMI over 27 plus weight associated.
But surely there's a lot of people using Ozempic for weight loss that are not obese.
That's like a kind of casual use. But then again, we do have patients that this medication is really necessary. So such as, like, let's say if the patient has infertility due to obesity, if the patient wants to go for kidney transplant they won't do the transplant would be postponed just because the patient is overweight, or cardiac surgery or hip surgery. So this patient can do good. That's all I'm trying to say.
Who have you said no to?
Those patients that they come for the casual use, not for medical use. Those are the examples I mentioned. Those are medical use. Those patients really need.
So give me an example of somebody who comes in for casual use.
Wedding, for example. I have a wedding coming up, and I'm
Give me a couple of shots, doc.
Vacations. The vacation is on the beach. Like, oh please, or some.
And people literally come and ask for that.
Oh yeah, or like some patients that they
any خجالت نمیکشن. They're not. There's not like they don't even need a pretense. Like it's like, I'm going to the beach. Hit me up with some Ozempic.
I like that they're being honest. Actually, I can be more helpful when they are honest. And so this is what I call casual use. So for the casual use, I never, like, it really depends. They really have to meet the criteria. And I explain, first of all, there are side effects. And plus, this medication have been approved by Health Canada only since 2011. So we still don't know down the road
since 2011 for diabetes.
For diabetes.
Not even for weight loss, right? Yeah.
No, not for the weight loss. That's true. Yeah.
By the way, I talked about it being FDA approved. That was the United States. What's the status of Wegovy or Ozempic in Canada in terms of the being approved by the medical establishment?
It's similar. It's similar to States. It's for the diabetes and Ozempic for weight management, but it's not necessarily covered by the public insurance. So they should have.
One of the things that Dr. Afrouz was seeming to say there at the end was that, if somebody's intent on getting Ozempic or something like it, they're going to get it anyway. You can get it anywhere. You can find it in Mexico or online or something like that. So better you or somebody like yourself be the person administering it and overseeing it. What do you make of that argument?
Well, I must disagree, because I would do my job and I will try to give them information. I will tell them why we are not giving this medication to the patient. Okay, so for example, I explained about the complications, adverse effects, side effects, and how this medication might not even work for them because they have a eating behavior issue. Not necessarily. It's just they're not even if they lose weight, they're gonna regain. It's gonna be kind of yo-yo. So, but yeah, because I'm not sure me prescribing a medication that is not really indicated would be a good thing.
So when you talk about them yo-yoing, weight cycling, that's correlated to the idea of you gain weight again if you go off Ozempic, right? Not if you stay on it. In other words, if you stay on it, you might gain weight back?
I do have patients that actually they have some regain, maybe not all of it. Again, it goes.
It stops working, or
because so for that matter, we have to actually focus on the mechanism of the effect of this drug. There are certain mechanisms. One of them is affecting the hypothalamus, which is kind of targeting your appetite, suppressing your appetite, and you will have early satiety. The other mechanism is
you'll have early what? I'm sorry.
Early satiety. You will feel full early.
Okay.
Like you just.
That's what Ozempic does, isn't it?
Yes,
Right.
yeah, this group of medication, and then it's kind of delays gastric emptying, like the stomach, like the turnover of the food will be slowed down, and you will feel full again. So because of that effect, affecting on weight gain hormones such as ghrelin, and adjusting other hormones such as leptin, which these are like the effects that it does, and of course effect on the insulin. But if you're, all I'm trying to convey this message to my patients that if you eat as a habit, okay, and you eat, you can say, oh, I'm on Ozempic, I'm on Manjaro, I'm on this and that, so I can eat whatever I want, and no matter what portion size, how often I want. That's not gonna work, and you might still gain weight. And I do have patients that they might lose a little bit and regained, or they might even, like, they didn't lose at all, zero. So I think that we have to say that's something that we, as a physician, as a healthcare worker, we have to focus on. First, find the issue. Where is the issue? If the issue is lifestyle, focus on the lifestyle first. If the issue is eating behavior, so then focus on that. And then medication. Is the medication indicated or not? So that's the way I think that should go.
When we talk about complications, what comes to mind for you as the thing that you're most worried about, honestly, in the big picture, or zooming in on Ozempic in your daily use?
So I will divide the complications into two categories. One, the more common one, but maybe less dangerous, and then more dangerous but uncommon ones. And that's the way I explain to my patients. So the more common ones are gastrointestinal symptoms such as nausea, vomiting, constipation, and diarrhea. That's, well, it's very annoying, of course, and that might cause the patient kind of interrupt the medication, and the medication effect will kind of, will be less, and it won't be like optimized, as opposed to less common but more dangerous side effects. Are, for example, thyroid cancer, a form of rare thyroid cancer, and pancreatitis. So these are actually quite serious. Biliary disorders like as gallbladder stone, and these all could be side effects. There are also some.
But what are you most worried about?
Well, I
all of that, I guess.
For sure, yeah.
I mean, they were saying that some of those serious ones are really, really rare. That's not a really, they're not really realistic. But
yeah, we have to see which patients we are looking at. If the patient already is starting with the like high risk thyroid nodule, and the patient is from the ethnicity that their like thyroid cancer is like quite very common, I would be worried. It's not like, oh, okay, because this form of like medullary thyroid cancer is quite very rare, so no, I would still make sure, like I will explain everything to the patient. I will say this is it, and then I will do the physical exam. I will monitor the patient. So that's a difference if the patient start the medication with a physician, as opposed to they get like kind of Ozempic, not in Canada, outside Canada, as a like over the counter.
Yeah. Well, don't you feel like that's where it's headed? I mean, there's now there's the pill you can take, right? Of Wegovy or something?
It's semaglutide Rybelsus, but it does not that much effective for weight loss. It's more for diabetes.
But it's that. See, this starts to sound like the future, like that we used to think, like something where you take a pill and you stay skinny and you look good and you're no longer an alcoholic.
Sure.
But that's also why I don't trust it. I don't believe that anything's all good.
I mean, I cannot predict and prevent patients from accessing medication, but all I can do is consulting them. I'm a consultant, telling them what's good, what's bad, and then they're adult. They make a decision.
Are there concerns? We were talking about Ozempic face, and do you ever have concerns about something like this being too effective, in the sense that there's dramatic weight loss over a short period of time, and that's actually not healthy as much as it looks good at the wedding or the beach or whatever?
That's actually a very good question. Yes, we do. Actually, that's one of our concerns as an endocrinologist. We do have seniors senior population for the diabetes. It's a very good medication because I just have to add this, like other medication, there are several other diabetic medication. When the kidney function is not optimized, you have to adjust, you have to cut down. But GLP-1 agonist, the whole family, and Ozempic specifically, you don't necessarily have to. I mean, up to certain level, and it's very good. It controls the sugars. Then it won't necessarily cause severe hypoglycemia, but unfortunately, I've noticed, and this is actually a kind of common knowledge, it will cause weight loss in elderlies. Weight loss in elderlies, we don't want that.
We don't want that.
No, because they will lose muscles. One of the adverse effects, they lose muscle loss, and they will fall. They have like increased the number of falls. So we really don't want that. So
you don't prescribe Ozempic over what age?
We do have other options. This family, they're like, I think 6 or 7 different members in this family. So like Rybelsus, the pill that you mentioned, has a less weight loss effect. So I might go with that. Or for whatever reason, if I go with one of the injectional, I will monitor them. And as soon as they reach certain point, certain percentage of their original weight, I will hold it. We will monitor their weight on every visit. Yeah.
Is you used to work with the World Health Organization,
Yes.
and you come from Iran. I mean, you're here now, obviously. How I was actually, Dr. K was saying that there's a lot of people interested in Ozempic or whatever their version of it is now in Iran. Mm-hmm. How global is this? Is the obsession with Ozempic? You tend to think of it as like a Hollywood thing, but I mean, has it become an international obsession?
I would call it Ozempic fever. Even Elon Musk, I think that he mentioned that in his Twitter. Like it's everywhere. Like they're coming, they're new immigrants, and it's like, okay, how about Ozempic? They're like kind of asking me about like they go directly.
I had a little extra Vaziri last night. I need some Ozempic.
Exactly. Yeah. Like I feel depressed. I really need that. So like this quite very common. Very common.
And sorry, you mentioned depressed. What about that? They've talked about it dulling things like anxiety and addictive qualities. And is that something you've noticed?
Well, those patients, when they mention they're depressed, it's just because they're like, usually because of their body image. They have a issue with the body image, and well, if they meet the criteria, sure, but like they still need to talk with someone, a therapist, psychologist, because that body image issue, I mean, should be resolved properly and should be addressed. But if Ozempic actually can resolve the issue, not necessarily. No, they will be momentarily happy because they lost some weight, but they kind of, from my experience, they get kind of dependent. And then as soon as because at some point I titrate down the dose of Ozempic or GLP with the whole,
and how do patients feel about that?
They're scared.
They don't want it.
They keep calling me. Yeah. Oh, can I see you again? Can I see?
That's what freaks me out about it. Yeah. The idea of being on a drug forever, needing to if the effects are going to be lost if you stop, then you're signing up for an injection of something that hasn't been around for 10 years forever. It seems crazy. Yeah. Not to take anything away from the people who it's helping. I'm speculating. I don't know.
I mean, there are several patients. Probably they hate me because I said no. So from the beginning, I would be very direct with them, and I would very clear. So no, you should go. Your issue is behavioral issue, meaning that you have to follow a healthy, balanced lifestyle, and you have to try that. You don't meet the criteria, or it's very high risk. For example, you had a history of pancreatitis in the past. So I would say no, and this is the reason. For those that I say yes, it's not necessarily right now. There is usually if we have time, it's not the case of upcoming surgery, transplant, or infertility. I will show them my plan. This is my plan. So the plan is you're going to implement diet and exercise as your routine. You have to open time on daily basis. And then we're going to start the medication, if you actually still need it, some of them they lose weight and they reach the target by just balanced diet and exercise and talking with the therapist and having the support. And then we will, if that's still needed, we'll start the medication for a certain time, and then I will go down, titrate it off. I would not continue. It should be monitored, and that's one of the reasons I do not necessarily prescribe like with many refills. Yes,
It's very good having you here. Thank you for the insights. If you were to, and before I let you go, who are the people other than those who come in needing this drug for type 2 diabetes or somebody who's very obese? What's the demographic? What's the profile of someone who's coming in looking for Ozempic?
You mean that medical indications?
No,
other
I'm actually talking about, does it break down on gender lines? Is it young people? Is it old people? Is it rich people? Who is it?
I do have a variety of patients, really, elderlies, younger ones. Well, younger ones, not necessarily, but maybe there are more number of patients with the body image issue, and because they're very busy, they don't have time to exercise, or they don't have time to prepare a healthy meal. So that's the issue, and they say like, oh, we need help. And for elderlies, there are other issues. So for example, they have knee pain, they can't really do exercise that much, or some of them, they actually can't do cooking, they live in senior houses. So it's like, okay, what can I do? I can't exercise, I can't prepare my meal. So what are my options? And I
the young person who says, I don't have time to exercise, that's ridiculous, right? I mean, I get it, that it'd be really fun to just get an injection and not have to worry about going to the gym every day for the next month, but that would concern me.
For sure. I explained that, like, listen, if you lose some weight with this medication or any other weight loss medication, you will regain. Without exercise and diet, you will regain and might even go over. So
thanks for doing this. Dr. Jaleh Hassanloo. She runs her own practice here in Toronto, treats a wide variety of hormonal and metabolic conditions. She's also an endocrinologist and internist at North York General Hospital in Toronto. Thank you so much.
You're welcome. Thank you.
All right. Pega's back in the studio. Our Ozempic debate is done for now.
Wow. That was...
Well, did you learn anything?
Oh
I learned a lot.
I learned a lot.
Okay.
I had no idea.
Like what?
Well, first of all, what we were talking about at the top of the show, the weight cycling, I had no clue. No clue about that. I didn't know that you could gain weight afterwards. And I really did think, this was a miracle drug.
Oh, you thought this was a miracle drug?
Yeah, I really did. I mean, what I've seen on
this debate tainted like your idea of Ozempic?
It
really?
Did, yeah.
I think of you as more skeptical than that.
No, because I had heard so much about this being a medication that has been around for some time. I know we talked about it, for weight loss having only been around for a couple of years, but what I had read about it briefly was that, they have been using this for years and years for diabetes patients, and that one of the effects of the medication is in fact weight loss, and that hasn't changed in the last 20 some odd years that they've been using it. It's just now there's new uses for it.
It's prescribed for those reasons.
Exactly. So I really did think, it's something that has been tested, tried and true, all of that, but I had no idea of some of the complications, side effects, and it not working in the long run, I guess.
Yeah.
But yeah, I definitely learned a lot.
When I think it was Dr. Afruz was talking about the nausea and things like that. I do know a couple of people who tried Ozempic and got really sick for a week or two and gave up. It's obviously not for everybody, even if we don't know what the actual long-term risks are or anything like that. But I felt like I had to push on the risk thing, and then Dr. K sort of was like, well, dude, every medication has risks. I mean, this is So it's
yeah, that part I agree with Dr. K. I mean, look, you take something over the counter and you look on the back of it and it's like a laundry list of side effects. I mean, of course, with something like this.
Yeah, but how long is the thing that you're taking over the counter been around? That's my thing. We don't know. We don't know what's gonna. We don't know, right? We don't. And like even these guys, even Dr. K, who's saying, "Oh, this has been around for a long time, since 2005." Well, that's not that long. And so who knows? You don't know what happens to people who've taken Ozempic 40 years later.
That's true, but I will say that with obesity at the very least, I would say that some of the side effects of obesity are more detrimental than the potential risks and potential side effects.
Yes, but what about the risks? What about the side effects of being slightly overweight on the beach?
Yeah,
are they worse than the side effects of taking Ozempic because you want to lose?
Listen, that beach vacation and those photos. But I couldn't believe it that
Dr.
is,
Jaleh.
Yeah.
Well, couldn't you believe it? I mean, that's the whole point, I think, of why Ozempic has become
so hated on,
controversial, because once it starts getting used as a
misused, I would say,
misused recreationally, almost like I'm going to pop an Ozempic because I got a date this weekend.
But how many other medications do we know that happens?
I don't think you can pop it yet. I think you have to.
I think it's injection.
It's injection.
Or now there's a pill of some
sort.
There's
the Wegovy, I think, has a pill, but yeah.
But what we're saying about misuse, I mean, I think there's so many other medications. I mean, being in university, like there were people who were taking ADHD medication to try and stay awake and study and things like that. So there's
people have essays to write.
Yeah, that's right.
Why are you attacking them?
So there's always other uses that people will find for medications and misuse it.
Yeah, I said it in the interview with Afers and Kayvon. I have a natural reflexive. Maybe it's the Iranian in me, if not the journalist in me. Whenever somebody says, "This is the miracle, it's good for everything," I kind of go, "Okay, hang on. Is
it really?
Is anything good for? I mean, what exists that is only good? Water,
to
maybe.
To be fair, I think all of our doctors were saying that this is not meant to be the kind of cure-all or
they were
saying
that. They were giving it the balanced approach, but I'm saying the idea that Ozempic is going to, I mean, at some point it was like it cures memory loss, and you no longer have addictions, and you'll have a nicer eyes. I don't know, like it's like I was like, oh, I guess I got to take this.
I think if you take it with the proper care instructions under the guide of a physician, all of these things, if you continue to work out and you take your fruits and vegetables daily and all of that, I think it's okay. But
any other comments on what any of them had to say?
The microdosing was also interesting for me. That Dr. Afruz was saying.
She prescribes smaller doses. Why was that interesting?
Well, because maybe I wasn't misinformed, but I thought it was only specific doses.
You figured you had to binge them?
Yeah, well, that's the thing, because there's this whole concept of you have to up your dose and you have to increase doses and things like that for it to work. So I didn't know that if you kept it at minimal doses, it would still have an impact. But that was cool.
All right.
Yeah. Go read up more on Ozempic now.
Yeah. I'm trying to think of what's Nusha Farine concert in Toronto this weekend.
This Saturday.
You going to go?
I'm going to try.
Good. There's something called Silk Road Canvas, also in Toronto. If people are around on Saturday afternoon, before you go to the Nusha Farine concert.
It's going to be a busy Saturday.
Young and Shepherd and the local shout-outs. But if anybody's in the Toronto area, it's like a combination of, it's like a cultural event with a lot of Iranian artists and stuff. Silk Road Canvas, Nusha Farine.
Can we ask our
Arsenal
local...
Chelsea, also an Iranian local Iranian event happening on Sunday.
Can we ask our local artists and events and things like that? Do it on different days. Now I have a full Saturday and nothing to do on Sunday.
Yep. Oh, there's lots of things going on Sunday as well. Thank you, Pega.
Thank you.
Thank you to everybody for watching us. Thanks to the amazing team who put this show together each week. Smart Pega, Seppi Wonder, Savvy Roham, Tina, the photo and video queen, and of course Super Parisa. And special thanks to Bearded Omid, Methodical Kabe, Solid Samin, and Talented Anahita. Thank you to all of you out there for supporting us and sharing our content. Please do subscribe if you haven't done so already on any or all of our platforms. You can find our show on Instagram at Roqe Media. You can find me on Instagram at Jian Gomeshi. And as ever, Mizun Bashi.